from the Psych Hub Podcast Network.
Hi, everyone. Welcome back to the Burnout Antidote, infusing well-being into healthcare culture. I'm Amy Pearlman, and here today with my colleague.
Hey, Paul Dager here. Good to be with you, Amy.
Today, we are talking about tech in the healthcare space, which I feel like is something everybody's talking about these days.
Yeah, especially with, AI taking over the world. And so it's certainly affecting healthcare as much as every other aspect of our lives.
I agree. So it's seems to be a hot button. I think even when we looked maybe 10 or 15 years ago with the EHR and electronic components of the days of kind of that doctor scribble have been replaced by this idea of getting everything into electronics, getting everything into this technology bubble.
Yeah, and this is another one I have unique experience, Amy.
I know.
I was an Epic trainer for those folks, and I'm sure there's a certain number of people just had their eye twitch and when I mentioned the word Epic. But I was an Epic trainer and then support, went through several go-lives in different hospitals. And really, I've had the frontline experience about it was seeing it didn't just change documentation, it changed so many things within a hospital setting.
And I was at this point in time, I was at a community health center. So really working on the implementation of electronic health records from that component. And it felt like a change to culture in addition to a change to documentation.
Yeah. Well, we have two folks who shared their experience of technology and impacting how they worked. Let's go ahead and take a listen to those.
I am a 38-year-old orthopedic physician assistant at a large academic institution in Maryland. I am also a new mom to an adorable dinosaur-loving 2-year-old. Early in my career, I was ambitious and I wouldn't hesitate to put in a 60 or 70-hour work week. Yes, I was busy, but a lot of factors contributed to those long hours. I didn't understand how to be efficient. I would never say no to coming in early or staying late. I was very green and I didn't know that I could stand up for myself. Speaking up for yourself to these orthopedic surgeons is not easy. I'm still learning how to do that. After nearly 10 years of the grind, I realized that those long hours were just not sustainable. I was 35 and exhausted. It was my first experience of burnout. So I am 10 years into my career and feeling burned out. I was also expecting my first baby, and I realized that I needed a change. I was able to negotiate a 4-day work week, and COVID allowed for some allowances to do administrative work from home, which was great. I became way more efficient and confident. I was able to be home to get my baby out the door most mornings. My system was working, but life doesn't work like that when you are a healthcare provider in today's world. Something had to get in the way of a working system. What I have learned is that burnout has many sources and it comes in waves. In my experience, the main contributing factor has been the enormous amount of administrative work that has nothing to do with patient care. When I'm tasked with a call to an insurance company, a lack of enthusiasm is an understatement, and I feel no personal accomplishment. Administrative work comes from patient communication, insurance denials, electronic medical charting, and much more. I currently spend more time doing administrative work than I spend with patients. This is a very noticeable change from my early days. A poll by Doximity shows that 46% of physicians believe that decreasing administrative work would be most effective to decrease physician burnout, as opposed to only 6% who prioritize salary, autonomy, and respect. I find this interesting. I would think that more money would be a priority for any physician, but clearly the administrative work is more offensive. So my administrative work from home is great, but it also has created a blurred line of work and home time. My computer is often at the kitchen island, and I find myself checking email at 9 at night. Why? Patient portals have been great for communication, but it has created direct access to the provider. This is great for patients and is generally a good thing for patient care. However, this places a lot of tasks that would normally be addressed by office assistants on my desk. Most patient questions are straightforward and can be taken care of quickly. However, Many ask for letters to be written or have messages that span on for several paragraphs containing multiple part questions. Patients expect a timely response, so you have to stay on top of it. It seems endless, and the messages like to accumulate on the weekends, which is a great Monday morning gift. The administrative work doesn't stop there. There are disability forms, workman's compensation forms, FMLA forms, and they have not gone away. But what has grown exponentially in the last few years are the insurance denials. It seems that each insurance company has their own set of standards for approval. They can deny imaging or a surgical case based on their own specific criteria, and it is very clear that a surgeon was not consulted when these criteria were created because they make absolutely no sense. It has now been bestowed upon the healthcare provider to contact the insurance and combat this out in a peer-to-peer discussion. This specifically falls on the physician assistant. Surgeons just do not have the time nor the patience to do this. Last week, I had 8 of these insurance denials. I recently read an article called Death by 10,000 Clicks. Boy, that's true. I counted how many clicks it takes for me to put in an x-ray order. 14 clicks plus 3 fields to be filled out. Wash, rinse, and repeat for 24 patients in a clinic. 10 years ago, I could give a verbal order, and that was it. The article found that the burden of electronic medical records was staggering, and residents were spending upwards of 20 hours per shift working on charting. Interestingly, one of the discussed solutions was to shift some of the work to physician assistants. We already take on the majority of the paperwork that would normally be addressed by a physician. There seems to be a huge and growing realization that burnout in the healthcare system is largely associated with electronic medical records and paperwork. But in reality, I've only seen it get worse. A PA lives in the middle of this medical world, and we seem to be a common dumping ground for busy work. The inefficiencies of the system should be identified and addressed as opposed to shifting the work from one group to another. Burnout is a common topic among my friends and colleagues who I work with in different roles. I, like many of my colleagues, am trying to walk the line of a successful career and a satisfying home life without sacrificing too much on either end. There's been a baby boom in our office, so we are all balancing the new mom life and our careers. Administrators in our department are pushing for the advanced practice providers to generate more income, but there's little discussion of ways to improve the system. I now fear that I'll be forced to go back to a 5-day work week, which would essentially destroy the balance of work and home life that I finally created. And if I see more patients to increase my revenue, I'll just have more administrative workload and less time to do it. I hear myself and I'm annoyed because it sounds like all I do is complain. I've negotiated a schedule that works for my family. I have great patients, and I'm thrilled to see them happy after a successful joint replacement or even a cortisone shot for some pain relief. This is what I signed up for. That is way more satisfying than an 8-hour day clicking away on my computer or on the phone going through prompts to get through to an insurance company. Burnout has been acknowledged and talked about, especially after COVID and the subsequent short staffing issues just about everywhere. But where is the action? There is a solution to the administrative burden out there, but when is it going to become a reality?
So first, I have to admit that I'm old. My first computer class involved punch cards. I'm not on social media, and I text my children in complete sentences with punctuation. But I'm not a Luddite. I embrace technology, especially at work. Mainly that might be because I lived in the pre-electronic medical record era. I experienced the frustration of trying to find paper charts, lived through transcription errors and illegible handwriting, experienced time wasted waiting in line at the radiology film room while someone searched for the x-rays I was looking for, and saw patients in clinic who were referred for an abnormal x-ray, and there was no x-ray and no one could find the written report. So I like the electronic medical record. I think most of the things physicians blame on the electronic medical record aren't really the EMR's fault. Cut and paste errors, long, irrelevant notes, time spent charting, those really aren't the EMR's fault. The EMR is a tool that can be used either for good or evil. With that being said, there's one part of the electronic medical record that's been causing an increasing amount of frustration, both for me and I would bet a lot of other physicians. And that is the EMR-enabled secure messaging portal. Also goes by patient portal messaging, inbox communication. It's a system that allows patients to send messages directly to their physicians. It was first introduced years ago, was billed as a time-saving device, and I'll admit I loved it. I no longer had a stack of phone calls to make at the end of the day where I had to find the right phone number and the right time to catch a patient, but now I could asynchronously communicate with patients and answer these little questions. But most systems turned it out without any support or really understanding the volume or workflow of what this was going to evolve into. And then the problems started. Its use exploded during COVID. There was an expectation on some patients' part of 24/7 access and communication. And I think there's a lower threshold to send electronic messages and questions rather than pick up a phone and fight through a phone tree to send a message to a physician. This also overlaps the time where there are a bunch of other demands on physicians' inboxes, most notably making prior authorizations. And some messages just became too long and complicated to deal with in that medium. This has gotten so bad that some systems are contemplating charging for time spent answering these questions. And when that first hit the news, my inbox was flooded with physicians asking questions about hey, can we do this? It's become such a problem that UCSF has set up a one-day conference just on managing the EHR inbox. Now, on the whole, I think this type of messaging is probably a good thing, but systems need to figure out how best to use it, how best to support it, and how best it fits in the entire system.
Those are really different perspectives when we think about technology, what it means in the workplace, and also what it feels like to the individual. I think I would be remiss if I did not say death by 10,000 clicks was something that just
that
like
quote.
stuck with me. And I was like, ooh, I feel like I may use that one.
Yeah, that was probably the quote that stuck out the most. And, there was something really wise in that first story around, I think there is this, moving stuff for someone else to do it is not the solution to the problem. And actually, I remember when I was training doctors who they were used to giving verbal orders for nurses to enter them in old paper systems. And then when we trained the doctors, suddenly they had to put in all their orders and the grumbling that came with that. But this idea of shifting the burden doesn't solve anything. All it does is increases someone else's workload. And I really loved how she spoke to, we have to address the inefficiencies, that there's systemic issues here, not just dumping on someone else to do it.
It stood out to me that this is an us problem, a systemic problem, and not an individual problem. So when we think about burnout in general, we are talking about that as it feels like an individual issue. And this idea of pushing the work off of me to make my work day feel smoother or more efficient when it affects someone else is this communal identity of the problem, or the communal.
The solution needs to include us all. Yeah.
So I appreciated that.
That other quote about where, there's identification of a problem, where is the action? And recognizing that with these systemic issues, that identifying the problem is not enough, and getting the right people in the room to figure out that solution, to have a really good discussion. I tend to be an operations person, and wanting to look at, start to finish, where are things breaking down and where can we make better use of all sorts of resources.
I think about that in terms of what makes the most sense. There's some like logical components here. I think there are also, the more that technology is available within healthcare, the more technology is available around healthcare as well. And I started thinking about I guess I started thinking about Dr. Google as a component. So this idea of, when you think about Dr. Google, you haven't heard this phrase, Paul?
No.
This is really the idea that as a patient, I have access to so much information on the internet.
Okay.
that I think I'm
Yeah,
going to
yeah.
Google my problem and try to solve it without engaging
Okay.
in a healthcare kind of relationship component. So we've been talking about technology and what does that look like in the healthcare space
Yeah.
for clinicians. I do
Mm-hmm.
think there is a component here for clinicians because you get you get a more educated consumer. And is that
True.
consumer educated from a reputable source? You don't
Good
know.
question. Yeah, yeah.
So, and as a patient and putting our patient hats on for a moment, you could save yourself a copay, you could save yourself some money, you
Yeah.
could save yourself some kind of heartache or worry in terms of the wait to get in to see a doctor by Googling this information, but you don't
Mm-hmm.
necessarily know what to trust.
Yeah.
Um, I just started thinking about
Well,
that information.
yeah, no, that lends itself really well, I think, to our second story, going really into understanding the patient portals and patient messaging. And what I'm hearing is the law of unintended consequences. Because initially it's like, oh, let's make easier, less friction in communicating with your doctor. Sounds like a wonderful idea until you unleash it without really thinking through how is this going to be used. And so I think Dr. Google and patient messaging collude.
Mm-hmm.
So now you've got the patient, because I was actually talking to a dear friend who was a doctor this weekend, and he said the novels that get sent to him sometimes that you really can't get to what is the ask, what is the need, and how much time is being burnt with someone sincerely reaching out, but they're communicating in a way that actually slows the whole process down.
The other thing I was thinking about is those emails that are way, way, way too short and don't give enough information and are asking
It goes
for
both ways.
are asking for a diagnosis in the like, I have an itch.
Right.
What is it?
Yeah. Well, think about a continuum of care, which I've been part of with mental health, in that there's, digital self-care, there's coaching, there's therapists and psychiatry. And you want to get the best fit and sort of max out that level to free up the real person time for the situations that need that. And it does make me wonder that I think sometimes that patient messaging crosses a threshold to, no, this needs to be in office. Maybe this needs to be a phone call. But I think in some ways people get so used to just typing things out. There's a sense of, well, this should take care of it, without understanding that, no, that there is a higher touch, higher contact maybe needed here.
That makes me think of a conversation we had in a previous episode around what is the right way to have a conversation, whether it is email, in person, and how do you make those decisions around in person
Right.
versus virtual care.
Yeah, good point. I'm going to reference Coming Back Better again. By the way, folks, great podcast, but I'm biased. It was one I was part of before. And we had a whole episode on tech coming into healthcare, and talked to a couple amazing researchers, doctors. One was, I think, a psychologist. The other one was an MD. And this idea of the fear of especially AI, um, and recognizing it's just another tool, but it's a tool with amazing power. And so this idea of unintended consequences, I think systems can make good use of tech, but there needs to be some really good thought given to it, and making sure it's not to replace the human touch, it's to enhance it.
That's a good way to think about it.
Mm-hmm.
Think about it in terms of self-checkout at the grocery store and not trying to take anybody's, jobs out of the way. But
it was funny. I was thinking about this episode, and I was at the airport this weekend, and they have the moving sidewalks, and I thought, well, that's tech. And a lot of times I choose not to use that because I want to get, stretch my legs before I'm going to sit on a plane. But after a long day of flying, it gets me home a little quicker. And I think that's the perspective that I bring into tech about giving some discretion when, where, and how we use it. Because I think so much of it becomes habitual. And I think there's even some, endorphins released with some social media studies, that we need to bring a consciousness to how we're using it.
great. Can you speak a little bit more around social media?
Yeah, there's been so much around. Well, geez. Okay, don't get me started on this. Where I just got flooded with so many directions to go, and recognizing one, I think there's people sharing information that, like you said, back to, is this source good information for medical advice? There's the literally addictive nature of, I get a little endorphin release, a little rush when somebody likes what I said.
Yeah.
And we forget how to talk when we use social media, apparently. Um, but I think there is this component of, now, I think there's people with different conditions that have found amazing community in social media. So I'm going to come back to, it's a tool. Back in the day when, we had our first hammers and they made carpenters more efficient, we didn't say, oh my God, tools are going to, hammers are going to take over the world and replace carpenters. I think it's just a healthy middle ground that we need to bring to all this technology and use it to maximize the human contact, the human relationship, rather than replace it. I think that's my take home.
And I think having it as a tool in the toolbox is helpful. I also think about the diversity angle to some extent with what can be missed. A lot of these technology components or Google or social media, they are really taking this kind of streamlined approach of the majority, and they don't know the same history of what makes up a human being, that relationship with a clinician brings.
Well, and I think we have to speak to algorithms, which drive, this is the coding that drive all this technology, especially AI, and that old idea of garbage in, garbage out. And if all we have is, what did, I heard this one researcher say, he doesn't want to trust, they were talking about actually self-driving cars. And there are moral decisions about when the car, it's the old trolley problem.
Yeah.
Do you make a choice of, do you take out one person or let 5 people be taken out? And we've got, he didn't want a 20-year-old wearing a pizza stained t-shirt, drinking Mountain Dew, making these moral decisions when they're writing the code, not to disparage any coders out there who like their pizza. But it should be like a group of, these are big discussions we need to be having. And when we look at the algorithms that drive, and this is not new with tech, there's decision-making tools that have been used for decades by doctors and healthcare folks that had bias built into them. So there's a negative human element that we have to make sure we keep an eye on when we build these algorithms, when we build out this tech, that it is inclusive of all different types of folks. That was a rant, but it felt important.
It felt important to me too, in terms of thinking about, even when we think about the evidence, and algorithms really are built on evidence to the most part, but that evidence is sometimes built on a bias, and looking at those samples and figuring out who and when do algorithms work for.
One of the quotes that came from our second story is, he wasn't blaming the tech, he was blaming misuse of the tech. And that's where I think we start to become mindless. And, again, that death by 1,000 clicks, it's not somebody's fault when they become mindless. But if you're having to do, how many clicks did she say that first story per authorization? That is like numbing
or something, but
like sitting in front of your computer for hours on end doing all that clicking, you are going to be numbed out. And you are going to probably start to just take the easy route, not through any fault, but technology sometimes gives you an easy route that maybe we need to pause and ask a few more questions.
I think it's when you start having that feeling of, what do I need to click on to just finish this?
Yeah. And I've been there. I'm sure we've all been there, about how do we, what's the quickest number of clicks to get this done? And that's when we've lost the human touch.
I agree. And I think there is this component of multitasking, which comes up everywhere. And I know Paul and I have this conversation too. I'm guilty of multitasking. More so when I'm
holding
stressed.
Back. As a mindfulness teacher, I'm holding back right now.
I know. It's funny. Every time I tell Paul I'm multitasking, he holds back. I think this piece of having like the screen between us makes
Yeah.
it feel like you can pull back and engage in all of these different components of technology. Having your phone attached to your hand while you're on, while you're typing, while you're talking to multiple people at different times is just the opposite of the kind of mindful awareness that we see as a protective factor or part of our
I
self-compassion.
I always find it funny during a Zoom meeting if somebody keeps their camera on, watching where their eyes are, and you can just quickly tell, okay, this person's not participating anymore.
And there's actually technology, Paul, not to interrupt you, but there is technology that they have that gives a kind of a score of how engaged people are in calls. And I used to work with another company that did this type of
Oh,
technology. And every
interesting.
time I
Yeah,
got on
yeah.
the call with them, I'd ask them if they were using their product while we were talking. Because I was so nervous. I was like, I promise I'll pay attention, but don't run your analytics on me.
No, don't run your analytics on me. That should be a t-shirt or a
Yeah.
bumper sticker. Okay, I know I can like rant all day on this. What do we have to offer our folks to continue the discussion and practice a little around bringing the human back into use of tech?
So I think I would like to start with this idea of mindful awareness, just where we were going, thinking
Okay.
about those situations, noticing what goes on for you. If
Mm-hmm.
screen time or multitasking are increased, when are you more likely to do that? Or how much screen time may you be getting throughout a day? So thinking about
Okay.
opportunities to stay present in the moment, whether that is present through a technology platform or whether that is present in nature with yourself and taking a break.
I want to call upon another aspect of self-compassion, actually, just like we did talking about telehealth. So, in addition to a mindful awareness, common humanity requires being around humanity. And if you're finding yourself feeling sort of glazed over, now I want to respect introverts, and they may need this in a different way, but we still are social beings. And if you find that the entire day is just making direct contact with tech, I think taking a pause and we're seeking out some living, breathing human beings
Mm-hmm.
in whatever way you feel comfortable doing, so that we don't glaze over and forget ultimately patient care is about patients and clinicians' well-being.
I think that's a good place to leave it. So I'm not going to add a ton onto it, other than to agree that this idea of what we owe to ourselves and what we owe to others in terms
Yeah.
of real, genuine connection.
Speaking of connection, did we plan this out? Because after 2 tech episodes, I love that our next one's going to be about the healing power of telling our story. I mean, can you get any more human than storytelling that goes back, to sitting around the fire eons ago? So, whoever planned this out, nice going that we're following up tech with talking about the power of story.
I'm looking forward to that one, Paul.
Cool. Thanks. All right. See y'all next week.
Thanks. Bye. If you'd like to reach us, you can do so at podcast@psychhub.com. To be notified of new episodes, don't forget to like, subscribe, or follow wherever you're listening. And reviews are so helpful, so please do leave one if you can. It allows others to find us and to join along. The Burnout Antidote is executive produced and edited by Jacob Morrison. Research is assisted by Tekla Ross. Show artwork was created by Ornella Jangoli and Ashton Smith. A very special thanks to Juliana Castro, Alyssa Fackler, Trevin Stiegel, Andrea Womack, and of course, our pet, Pickles. The Burnout Antidote is a co-production from Psych Hub and is brought to you by Janssen Neuroscience.